I'm a clinical associate professor with ECU Health in the Division of Surgical Oncology. I'm a breast surgical oncologist by training, which means I did a 5-year general surgery residency, a year extra training in breast surgical oncology specifically, and since 2012 have been doing solely breast surgery. I got into breast surgery towards the end of my residency because it was the chances, I usually say, to be the best version of a doctor, a human being, and a surgeon that I could find within any of the specialties. I love the patient mix that you see in breast surgery and breast surgical oncology. It's a very scary time for them, and so being there to have the opportunity to try to make that as least intense as possible is just really worthwhile and gratifying to me. Well, my general approach, I would say, is just to be straightforward and honest and try not to sugarcoat things, but also give hope with the message that you're giving, because there is a lot of hope in breast cancer and the treatments for breast cancer in this current date. So I want to make sure they have realistic pictures of what this means for them when they are diagnosed with breast cancer or any of the other breast diseases that we treat, but also making sure they understand that there is still a lot of hope. There's a good chance of cure, even if it's breast cancer, and approach it from that perspective. I think the importance of this month is to introduce patients and people again to the fact that if we can screen patients regularly, then we can catch breast cancer early. And the earlier that we can catch breast cancer related changes, the best chance we have at curing those patients of that particular problem. As a surgical oncologist, it does a lot based on my physical exam and my appreciation for what changes a patient is coming to me with. But mammograms are essential in the identification of early breast cancer related problems. And now that we have contrast enhanced mammos and 3D mammograms, those have been found to be really good for dense breasts. And so we have a new category of studies for patients who fall into that category. And then we use MRI and ultrasound as appropriate for those patients who we think will benefit from that. Specifically, those patients who have been found to be at high risk for breast cancer can really benefit from a periodic or annual MRI. So we try to tailor the studies and the interventions needed to the patient sitting in front of us with their individual risk assessed and their history assessed, and any other abnormalities or changes we might find clinically. Since I began my training in breast surgical oncology, we have gone through leaps and bounds, and I think that the most change that we found is in our systemic therapies, our chemotherapy regimens, our immunotherapy regimens. They have done wonders in the overall survival for breast cancer. From a surgical perspective, there was a big shift from using wires to localize breast lesions prior to the finishing of my residency. Now we're using wireless technologies to help us gauge a more precise and accurate positioning for that individual lesion that we're trying to remove, with less discomfort for the patient and a better scheduling of the procedure and the localization so that they're separate and patients can be ready for the operating room when it's time for them to be ready. Kind of makes the flow of the day a lot easier for the patients and the rest of the staff involved in their care. And I would say overall, with breast surgical oncology, we are moving more and more to less invasive surgical techniques with the same opportunity to cure. So we're being much more smart about the invasiveness of our procedures, the invasiveness of what we offer to our patients, to really try to balance out the harm that we could potentially create with the surgery and the benefit that we would be providing that particular patient. And I guess on a final note in that regard, the technologies as they advanced have been able to help us tailor the treatments to the individual patient, and not just the individual patient, the individual tumor that type that patient may have. So that's been neat to see over the course of my practice too. We look at the actual genetic makeup of the tumor itself and try to help determine the treatments that are needed even based on that. So it's fascinating. And that's one of the other things I like about this specialty. It's very multidisciplinary. We have a lot of different specialists that we talk to, like the radiology team, the pathology team, the radiation oncology team, the medical oncology team. We're all very interconnected, and we work very much together to try to tailor the best treatment plan to each individual patient. For the average risk patient or the average risk individual, I would encourage yearly mammograms after the age of 40. For patients at elevated risk for breast cancer, I encourage breast awareness at 18 even, but screening imaging to start perhaps around the age of 30, so that we're not exposing so much to the radiology markers, radiology tracers, and radiation that you might get with some of those studies, but you're still at a very early age starting to really screen them intensely to make sure we're not missing anything. I think the most important part of this is to be able to identify a change early, even maybe before it's cancer, so we can talk about risk reduction. We can talk about what those individual, even high risk breast findings may mean as far as your risk for breast cancer in the future. We may even encourage anti-cancer fighting treatments, so to speak, without a diagnosis of cancer for those patients who are at elevated risk. And with risk assessment and genetic testing comes talk of prevention and prophylactic surgical procedures, which can really reduce the risk of breast cancer coming in the future. But I would say that the main thing about screening is just to identify a problem early so that it's curable, and curable with less invasive surgeries, and curable with techniques that don't involve more invasive things such as chemotherapy or bigger procedures or removal of all the lymph nodes in the axilla, for example, for patients who have the cancer spread there, those kinds of things. Signs of breast cancer can present with just skin changes. They can present with nipple crusting. They can present with nipple discharge, nipple inversion. We can see new lumps or bumps, new masses. We can see swelling of the skin of the breast or edema of the skin of the breast. That's a sign of a more advanced type of breast cancer. So that's why we talk about breast awareness and self-exam. So if you see or identify any of those changes, you can talk to your provider about that as soon as possible and get that taken care of, or at least looked at. So I would say that it's very important for each individual to know themselves and know what the signs and symptoms of breast cancer are so that they know what to look for. I would encourage everyone to know their own risk for breast cancer, and if they fall into the high risk category or average risk, and to get their screening imaging as recommended for that. And I would encourage patients or individual women and our men, because men can get breast cancer too, to just seek a physician's assistance if they note any change so that they can get things appropriately worked up, evaluated, and treated if it comes to that. Because males are 1% of all breast cancers, and they present at typically a little bit more of an advanced stage because they cannot undergo the same screening paradigms that women will. So it'll present as a new lump or bump or mass or breast changes, lymph nodes in the axilla, any of those things. So something that they need to be on the lookout for too.